we're going to be looking at mapping interventions to address social factors related to health. And this is something that I've been obsessed with for a few years, and I think it's even more relevant in the context of COVID. If we learned anything from the 2008 global financial crisis, where we saw a massive uptick in social need. So this notion that social need is related to health is not new. So this paper written by Hubsan in 1949, and later in subsequent slides, I'll show you some of the interventions around social need. Was really, quite interesting. And this is a quote taken directly from the paper. Today we realize that disease processes can be initiated not only by adverse factors in the purely physical environment, but also by adverse factors in the social environment, et cetera, et cetera. And then we scroll down here: a happy family circle, a full and adjusted community life at work and at play, a sense of purpose and responsibility in the world. These are of vital importance to social well-being. And this article was published in the BMJ in 2018. Life expectancy declines seen in the US and other high-income countries. So out of 18 countries in the study, all high-income countries, 12 experienced life expectancy declines among men and 11 among women. Now, there's a question as to whether life expectancy is the best measure of health, but it is a measure. And considering how much money we pump into healthcare systems, it's interesting that life expectancy is actually decreasing. And the US, where I'm from, this was published in 2018, but for the past 4 years, life expectancy in the US has been declining gradually. And last year, or the year before, the ONS published some stats where for the first time in several decades, the UK life expectancy was also stagnant and declining, depending on what demographic you're looking at. So where does this decline in health come from? And sort of corroborating Hobson's points, what we find is that there's psychological factors having social origins, including social exclusion, poor prospects for social mobility, high income inequality, are the contributors to bad choices that people, particularly in low socioeconomic groups, make. And the individual lifespan is dependent on these lifestyle choices. And what's interesting is, again, with COVID is not originally part of this talk, but it's interesting some of the stats that we see, because the BAME groups, who are oftentimes of lower socioeconomic statuses, are actually being adversely affected by COVID. And I think if you're a Black male, you're, I think, something like 4 times as likely to die from COVID as if you were a white male. Now, we know this is not genetics, it's due to the social factors. And what's interesting is, when we see this phrase bad choices in quotations, the reason why it's in quotations is sometimes and oftentimes these individuals in these groups don't actually have choices. And a great example of this is Tower Hamlets, which is a borough in London. So in Tower Hamlets, there's 42 fried chicken shops per secondary school. 42 fried chicken shops per secondary school. And in Tower Hamlets, they have a childhood obesity problem, which I guess is not very surprising, is it? And when we think of this notion of choice, do these children actually have a choice? Because it's either fried chicken or fried chicken. The shop that they go to might change, but the menu is pretty much still the same. So they don't really have much of a choice in these situations. And thinking from a cusp perspective, the built environment and looking at urban planning, why haven't we designed our towns and cities to allow these individuals to make better choices? And so if we go deeper into the root causes for how we actually need to build healthier societies, this is work by Wilkinson and Marmot. There's a few things: educational failure, insecurity and unemployment, and housing standards. And if these 3 sort of core things are not met, then they will lead to stress, early life social exclusion, work, unemployment, um, lack of social support, addiction, substance abuse, lack of nutritious food, and transport issues such that people have to commute an hour and a half or 2 hours each way, so about 3 to 4 hours a day just to earn a livelihood. So if we look at some of these factors in sort of a different way, what we see here and sort of highlighted in this red circle, for me working in healthcare, the obsession is looking at A&E attendances and reducing GP appointments, because that's the sort of throughput into the healthcare system that will then lead to further add-on costs. But if you look at health outcomes, defined by life expectancy and quality of life, clinical care only contributes 20% of health outcomes. The rest are the sort of remaining 80% are due to health behaviors, social and economic factors, and then physical environment. And what's sort of important to note is that the physical environment, social factors, economic factors, health behaviors are not mutually exclusive. They will be related to one another. So from a cusp perspective, this might, you might think that, well, only 10% is related to what cusp would be interested in or can impact. But all of these things are actually very, very interlinked in terms of the choices that people have access to. So from my perspective, I think urban planning and urban design is actually essential and is not a component that can be extracted from this entire ecosystem. This chap, Jeffrey Rose, was based at LSHTM, and he wrote a fantastic paper in 1985 called Sick Individuals and Sick Populations, and this is available open access if you click on this link. And in this paper, this is just the abstract, he distinguishes between the high-risk approach, which is looking at individuals who are at high risk of getting sick or getting an acute exacerbation of their existing condition. And a definition of an acute exacerbation, or an example, would be a heart attack or a stroke, or if you're a diabetic patient, then having your leg amputated because your blood sugar is not controlled well. So that's looking at the high risk approach, is identifying these individuals who are at high risk of an exacerbation, an acute exacerbation of their existing condition. Whereas what Jeffrey Rose talks about is the population approach, where rather than trying to look at these high risk individuals, you take a population approach where you try to control the causes of incidence of disease. So you try to prevent people from getting sick in the first place, where they might even inch into this high risk group. And he created this very simple heuristic where you have this sort of bell-shaped curve, and this is a bell-shaped curve that we would be looking at normally. We have risk on the x-axis, and we have the percentage of the population that gets sick on the y-axis. And most healthcare systems focus on the high-risk population. But if you look at aggregate morbidity, mortality, and spend, it's always in this middle risk bubble, because though they're lower relative risk, there's a higher number of people in this bubble. So the number of events in this bubble is always going to be higher. And what Jeffrey Rose talks about and advocates for is actually shifting this entire risk profile to the left. And there's a few things that happen, or a few things to note. Firstly, when we're looking at these different risk categories, the level of intervention needed is going to increase as you go from the low risk to the high risk categories of individuals. So the level of intervention that you need for an individual at a high risk group is always going to be higher than the level of intervention needed for a medium risk group or a low risk group, okay? And when you shift the risk profile to the left, what's going to happen is that what was your high risk population is now going to be in the medium risk categorization of intervention. So you're actually going to need lower intervention for your relatively highest risk group of people, if that makes sense. And the amount of intervention that you need for your entire population is going to decrease as well. So, in an upshot, the upshot of this is that this shifting to the left is looking at medium to long-term prevention and disease prevention and health promotion. And this high-risk bubble, focusing on this is just short-term symptom management. because you're trying to prevent acute exacerbations. Now, this is common sense, right? There's no sort of rocket science elements to this. It's always better to prevent than to have to treat somebody who gets sick. But if you look at how we allocate our resources, this was a publication in 2018 or 19 from the OECD, where they looked at healthcare budget distributions across OECD countries. And what they noted was that on average, only 2.8% of health and care budgets were allocated to prevention activities. And this is the breakdown. You see 9% for immunization, 7% early disease detection, 44% for healthy condition monitoring, and then 27% for information, education, counseling, and then 13% for other collective services. And this is what we see in England as well, where we see about 120 billion pounds spent here on the NHS, and only 3 billion pounds, 3.4 billion to be exact, spent for Public Health England, disease prevention and health promotion. So though we know about this, we're not actually putting our money where our mouths are, and we're not allocating the resources sufficiently to the activities that can actually help to keep our populations healthy and prevent them from getting sick. And the other thing to note here is that if we don't shift the risk profile to the left, this risk profile will continue drifting to the right, which is what we're seeing real time, which is why life expectancy is decreasing, why we're seeing 70% of our population being overweight, 30% being obese. And again, coming back to COVID, the majority of people who passed away from COVID, i.e. got the severe COVID, had pre-existing conditions. And oftentimes they had multiple conditions. And when you look at the list of conditions they had, again, the majority, so some had, sort of rare diseases, and they were, compromised if they were undergoing chemotherapy, etc. But the majority of people had hypertension, cardiovascular disease, type 2 diabetes, obesity, COPD, asthma, all of which are chronic diseases and can be prevented or brought into remission. So going back to the original quote, the 1949 thing from Hubsan, he didn't get that and he didn't make it up, right? So the notion around social medicine is actually pretty old. So the first mention or use of the term social medicine was in France by Dr. Jules Guérin. And then Rudolf Virchow in 1848, also in Germany, tried to put a little bit of structure to it, as I suppose you would expect from Germans. And they looked at social medicine because what they realized was that the health of their populations, and this was sort of during the Industrial Revolution, a lot of it was due to poor working conditions, lack of housing, lack of sanitation. And again, during that era, we see John Snow in London looking at cholera and the Broad Street Pump. And if you've read Dickens, you'll sort of realize that England in that era was actually not the best place, and there was a lot of child labor, a lot of poverty. Life expectancy was in the 30s and 40s during the Industrial Revolution and in Dickensian England, and that was almost seen across Europe as well. And so Virchow came up with these sort of three principles. The health of the population is a matter of direct social concern. So this notion was sort of the seed for universal healthcare systems. Social and economic conditions have an important effect on health, disease, and the practice of medicine. So what he's trying to point out here is that doctors also need to be aware and cognizant of these social factors, because if the doctor is actually looking after the health of the individual, they have to look at all of the factors that are affecting the individual's health. And then number three, steps must be taken to promote health and to combat disease. Again, nothing rocket science oriented here. This is all fairly common sense. But even from the mid-19th century to now, we still haven't done a good enough job of actually addressing these issues. And that brings us to present day. So in England, we now have a formal program looking at what are called social prescriptions. So the sort of formal definition is a way of linking patients in primary care with sources of support within the community to help improve their health and well-being. And so we have health and well-being included in here. So well-being would actually look at some of the social factors related to health. And the social prescriptions include a variety of different things like sports and physical activity, leisure arts activities like painting classes, singing classes, gardening clubs, etc. Activities focused on health, education, skills development. And the potential benefits, you can start addressing social determinants of health, you can promote self-care, create jobs through these local sources of support within the community. And you can also build stronger communities by having people accessing local services and local resources to actually promote their health. So to make this just a little bit more real, let's create 3 scenarios. So you guys are the GP and I'm the patient, and you've just diagnosed me with type 2 diabetes. Scenario 1 is sort of business as usual. So you will give me the entry-line therapy for type 2 diabetes, which is a drug called metformin. You give me metformin and you say, pick this prescription up and come back in, say, 3 weeks or 4 weeks to see how you're doing and how you're getting on, if you have any side effects from the medication, etc. Okay, so that's scenario 1. That's business as usual. Scenario 2 is you give me the pill, but in addition to that, you give me a patient information leaflet. Okay, and in the leaflet, there will be information about how I can modify my exercise habits and modify my diet to actually help me control my type 2 diabetes better. But you're still giving me the pill. Okay, you're still giving me metformin. Scenario 3 is because you've just diagnosed me with type 2 diabetes and I'm not past the point of no return, instead of giving me metformin, you will give me the patient information leaflet. And then in addition to that, you will ask me, what do I like doing in terms of physical activity? And is there something that I can modify from my diet to try to reduce the amount of carbohydrates I intake, etc.? And instead of giving me metformin, you will give me a prescription, because I tell you I like football. You'll give me a prescription to a local football club in the community, where 3 times a week I can train and I can play football with my community members, and I can start getting physically active. And in addition to that, you're going to send me to a cooking course on how to create healthier food that will reduce my carbohydrates, my carbohydrate intake, or at least my unhealthy processed carbohydrate intake, and then also help me to get a food plan. So if I want to eat carbohydrates, I should eat them before I exercise and not at night. I shouldn't have a carb-heavy meal, because otherwise that will just bombard my blood with glucose that won't be processed, and it'll just exacerbate my type 2 diabetes. So that's scenario 3. That's a social prescription. That's where you are going to try to train me to take care of my own health, and you're going to give me the confidence that actually I can bring my type 2 diabetes completely into remission by diet and exercise. And social prescriptions are being implemented at 3 different levels in the UK. The local level by GP practices, so St. Austell is an example, and St. Austell is based in the Southwest, and some of the GPs there actually do a really fantastic thing where they do surf therapy with their patients. So some patients who have anxiety disorder or PTSD, post-traumatic stress disorder, they'll actually take them on the waves in Cornwall, get them on a surfboard, and help them to sort of relieve their stress and anxiety by just being on the waves. Regionally, you have something called Ways to Wellness, which is in the Northwest, and it's a 7-year program offering social prescribing for up to 3,500 patients. And then nationally, we have the NHS England Universal Personalised Care Plan, and they're investing in 1,000 what are called link workers by 2021. And a link worker is somebody who can signpost me as the patient to the football club in my local community or the cooking class in my local community. So they have a better understanding of all the community assets within your locality. So they can signpost me to the community services that are probably most relevant for me and that I'm most likely to engage with. Benefits, 84% of GPs say they have an unmanageable workload and 20% of patients go to their GP primarily for a social problem. So if we tried to get this sorted out, looking at social prescribing, and actually did a better job of addressing social needs, we'd probably reduce throughput. And even if you didn't have a social need, so my type 2 diabetes wasn't a social need, but if you trained me to manage my condition better, then I wouldn't need to come back to the GP for an appointment to check on my type 2 diabetes. 80% of GPs say that social prescriptions should be available from all GP surgeries, and 59% acknowledge that social prescriptions could reduce workload, as I just mentioned. In 2017-18, there were about 69,000 social prescription referrals, and a variety of different benefits for reducing demand of GP services, reducing A&E attendances, and improving social return on investment. As a corollary, this 69,000 social prescriptions, I think, cost us about 44 million pounds across the NHS. And if we look at the prescriptions budget for drugs, we spend about 16 billion a year on drugs and medications, relative to the 44 million on these social prescriptions. That's one. The second point to keep in mind is, for the 16 billion that we spend on pharmaceuticals, 50% of patients with chronic conditions do not take their medications. 50%, 50. So even if they have generics and cheaper versions of their drugs, we're still probably wasting on the order of 2 to 3 billion a year on medications that are delivering zero benefit and are probably literally flushed down the toilet. Now, this is something interesting. When I've given this talk in Italy, they were actually surprised and shocked to see this. And many people in England or in the UK don't know this, but Theresa May, when she was Prime Minister, launched a loneliness strategy. And she described loneliness as one of the greatest public health challenges of our time. 75% of GPs are seeing 1 to 5 people a day suffering with loneliness. Over 200,000 people have not had a conversation with a friend or a relative in over a month. 20% of adults feel lonely most or all of the time. And loneliness can be as bad for health as obesity or smoking. And again, thinking about COVID with the social isolation and the quarantining, this is actually probably going to be an issue that's going to be exacerbated over time. And you can see some of the actions that were taken. So that now comes, that's sort of the background, and this is what we're actually doing now to address some of these issues. So this is a project that we're doing in collaboration with the Royal College of GPs, the University of Oxford, and is being funded by NHS England. And we're creating a public observatory through a network of 1,000 GP practices across the country. And for reference, we have about 7,000 GP practices across the country. And through these 1,000 GP practices, we get every week a full electronic health record upload. So we get all of their data. The data is then pseudonymized, and then it's available for analyses. This network was set up about 50 years ago, and it was set up to monitor influenza outbreaks. And we've actually created a dashboard, a public observatory for COVID as well. And what we're now going to do is to utilize this database to create the first public observatory on social prescribing. We're going to have multiple phases for this project. And phase 1 is going to look and map the number of social referrals and the number of declined social prescriptions. And we're going to disaggregate this based on geography and patient characteristics. And the goal with this phase of the project is to highlight variation, both warranted and unwarranted variation, in access based on geography and patient characteristics. So just very briefly, what do I mean by warranted versus unwarranted variation? So warranted variation would be if you have a population with a high level of social need, and you have another population with a low level of social need. Warranted variation would mean that we would actually expect the population with an increased or a higher level of social need to get more social prescriptions than the population with lower level of social need. So that would be warranted variation because it's explained by the demographic characteristics and the need of the population. Unwarranted variation would mean that we have two populations with the exact same level of social need, but population one gets a high rate of social prescription referrals, and population two gets a very low rate of social prescription referrals. That would be unwarranted variation, and it's a sign of sort of this phrase of postcode lottery or inequalities or inequity, depending on what the demographic characteristics are within the population. So this is a mock-up. So this dashboard will be live on May 24th. So I can send a link to the CUSP team once it's live, and we're just building it right now. So to start off with, if we look at the right-hand menu, we have a few things that we can look at. We can look at the regions of the country. We can look at age, IMD quintiles. So this is a measure of deprivation. So 1 is the least deprived, 5 is the most deprived. Ethnicity, gender, patient category. So are they suffering from a mental health illness, a severe mental illness, learning disability, domestic abuse, homelessness, and then status, COVID positive, COVID negative, or at risk of COVID. And this is going to be updated on a weekly basis. And we're going to look at the rates of referral per 10,000 population, rates of declined social prescriptions per 10,000 population, rates of people offered social prescribing per 10,000 population. And then we're going to see the rates of coding utilization. And the reason we want to see this is to control for poor coding within the GP EHRs. Phase 2 is we're going to look at the proportion of people with social needs receiving a social prescription. And we're again going to disaggregate by geography and patient characteristics. This phase 2 will be live towards the end of June. And what we want to start highlighting here is variation, both warranted and unwarranted, in access to social prescribing based on social need, geography, and patient characteristics. Now, social needs, we're going to start disaggregating. So we're going to give a taster with these different patient categories. So these give an indication of social need, but we want to go much deeper into the various social needs that people will be having. So again, if you look at the right-hand menu bar, we're going to firstly expand to different regions. So we're going to disaggregate to 7 regions. And we're also going to give this option of having what's called an STP, or a Sustainability and Transformation Partnership, which disaggregates this even further. So there's 7 regions and there's about 44 STPs. So we'll have a higher level of granularity when we map based on STP relative to these regions. And then we're also going to have a drop-down menu for social need. We'll have age, IMD quintiles, ethnicity, gender, and status, COVID status. We're going to remove the patient categories because these are now going to be incorporated into social need. And to give an indication of what we mean by social need, that will be mental health, severe mental illness, learning disability, domestic abuse, homelessness, sedentary lifestyle, parenthood, addictions, diet, employment, housing, education, stress, bereavement, benefits, finances, etc. Now, the reason NHS England actually signed this off is because of the anticipated massive increase in social need that we're going to have post-COVID. People are going to be unemployed. We're already seeing domestic abuse cases going up. So I'm working with some police in Surrey and in their work with folks in China, in Wuhan, the police in Wuhan, they indicated that there was actually a 3-fold increase in domestic abuse cases in Wuhan during the quarantine. And we're starting to see similar things come to light in some of the countries that are now coming out of quarantine, Italy and France in particular, and also the UK. Substance abuse will also be a huge issue. We're seeing the amounts of alcohol consumption and purchase have dramatically gone up in the UK during the lockdown. Malnutrition will also be something, so diet. So I think there was a study done about 3 weeks ago that was published and it indicated that 1.5 million people in the UK are going a full day without a meal. And that's because of lack of access, because supply chains and the supermarkets can't stock things, and also because they can't afford it, because they've lost their jobs. And there is a lag time between some of these benefits and the furlough schemes coming on. And then there's also the issue of the closing down of schools. So many children who sometimes only had their only nutritious meal provided to them by the schools now have no access to nutritious food because their parents are sort of below the poverty line. And this is what it will look like. This is the sort of summary data. We're going to map this as a heat map. And again, people will be able to sort of play around with this. So, and again, you know, from a cusp perspective, what we want to start doing is looking at the social need and then seeing from sort of an urban design, urban planning perspective, what can we actually do to mitigate some of these, the sort of upticks in social need that we're seeing across the country. So that's the end of the talk. And then this was a question that I was going to pose to the CUSP community and any of the attendees in the audience. How could information about social determinants be used by urban planners to deliver better health? And yeah, so that's it. Should I stop sharing or?